Welcome to This Explainer. Okay, if you're gearing up to take Exam 4 on newborn physiology, I just want you to take a deep breath right now. You are absolutely in the right place. Today, we're going to equip you with a totally foolproof test strategy. We're going to break down all that complex stuff, decode what's normal versus abnormal, and literally transform the way you tackle these clinical scenarios. Let's just dive right in. Seriously, I want you to ask yourself right now, are you just memorizing numbers? Like, are you staring at endless flashcards of vital signs, respiratory rates, and APGAR scores, just feeling completely overwhelmed by the sheer volume of data? Because here's the thing, if you're trying to brute force memorize your way through newborn interventions, you're going to hit a wall. Hard.
So stop. Just stop the rote memorization right now. Because to pass this exam, and honestly to be a safe, effective nurse, you have to know the why. We need to look at this through a totally different lens. With newborns, almost everything comes down to their transition from life inside the uterus to life outside. Once you actually understand the underlying physiology, like why their temperature drops, or why their glucose plummets, or why they're struggling to breathe, the correct nursing action, it becomes incredibly obvious, like a giant puzzle just snapping into place.
So here's our roadmap for conquering this material today. We're going to cover the master strategy, APGAR and transitions, the cold and glucose chain, preterm and breathing, jaundice and anomalies, and we'll wrap it all up with the ultimate exam cheat code.
All right, Section 1, the master strategy. This is your core framework for Exam 4.
Whenever you open a question on this test, I want you to run the scenario through this exact 4-step mental checklist, okay? This is your master pattern. Step 1, is this finding normal or abnormal? If it's expected, like say a tiny bit of weight loss in the first few days, you just provide routine care. No big deal. But if it's abnormal, you immediately move to Step 2. Why is it abnormal? Then, Step 3. What is the immediate threat to the baby's life? And finally, Step 4. What does the nurse do first? I promise you, this framework cuts right through the noise. It's going to lead you straight to the priority action every single time. Moving on to Section 2, APGAR and First Transitions. We're going to apply this strategy to the very first moments of a newborn's life.
Now, the core purpose of APGAR is actually really fascinating and honestly kind of misunderstood a lot of the time. We do it at 1 in 5 minutes after birth, and yes, sure, it stands for appearance, pulse, grimace, activity, and respirations. But please, don't just obsess over memorizing the exact points. The big why here is just to quickly figure out how well the newborn is transitioning to breathing actual air. So just know that a score of 7 to 10, they're generally doing great, but a 4 to 6 means moderate difficulty, they're going to need some support. And a 0 to 3, that signals severe compromise, which absolutely demands immediate resuscitative measures. So is this baby transitioning successfully? Honestly, that is the only question that matters here.
Right in the middle of those early transitions, we also give some specific routine medications. Let's look at the why for each of them. We do an IM injection of vitamin K right after birth. Why? Because newborns have incredibly low stores of it, and their brand new immature systems desperately need vitamin K to make essential clotting factors. So in your head, vitamin K equals bleeding prevention. Boom! Next, we use erythromycin ophthalmic ointment to prevent severe eye infections, specifically gonorrhea that they might pick up during birth. And the Hep B vaccine, that's given to, well, prevent hepatitis B. So for your exam, just remember this. Every single medication is basically just a bridge. It's a bridge to protect an immature system until it can function on its own.
All right, Section 3, the cold and glucose chain. This is a deadly domino effect, and honestly probably the most highly testable concept you're going to see. The cold chain perfectly illustrates why something as simple as keeping a baby warm is actually a critical, life-saving intervention. See, newborns have this massive surface area compared to their body mass. They have very little fat, and this is key, they cannot shiver. So, Step 1, a wet newborn instantly experiences heat loss. That heat loss immediately triggers cold stress. Now, cold stress totally ramps up their metabolic demand. And what does that mean? It means the baby starts rapidly burning through whatever oxygen and glucose stores they have, just trying to stay warm. So what's the immediate threat here? Step 5, hypoxia and really dangerous hypoglycemia. This right here is exactly why we dry, warm, do skin to skin, and put a little hat on the baby. Cold literally equals low oxygen and low blood sugar.
So building on that whole glucose connection, let's look at two extremes. We have the LGA, or large for gestational age baby, and the SGA, or small for gestational age baby. With the LGA baby, the classic culprit is maternal diabetes.
Mom's high blood sugar crosses the placenta, right? So the baby's pancreas goes into overdrive, pumping out massive amounts of insulin to handle it. That's what causes them to grow so large. But then, birth happens. Mom's glucose supply abruptly stops, but the baby's insulin levels still sky high. So what happens? They plummet into sudden severe hypoglycemia. Now, on the flip side, the SGA baby usually suffered from chronic hypoxia while still in the uterus. That led to poor growth, basically zero glucose stores, and a huge risk for hypothermia. So here is the absolutely crucial takeaway. Whether they are way too large or way too small, both of these extremes face life-threatening glucose drops. Your absolute priority action, check that blood sugar and feed that baby. We have to protect that newborn brain.
Moving right along to Section 4, Preterm and Breathing Risks. Here we're looking at the ultimate immature system.
Okay, so preterm babies, anyone born before 37 weeks, they face a ton of challenges. But respiratory distress syndrome, or RDS, is the really big one. The absolute critical cause and effect link you need to know here is surfactant. Premature lungs just don't have enough of it. It's that simple. And without surfactant, the tiny little air sacs in the lungs, the alveoli, they basically just collapse every single time the baby exhales. It's like trying to blow up a wet balloon. This alveolar collapse is what causes the classic signs: grunting, nasal flaring, chest retractions, and cyanosis. So when you see a preterm infant struggling to breathe, you instantly know the why. It's a critical lack of surfactant. And your priority action? Support their oxygenation and ventilation immediately. Don't wait.
All right, let's jump to Section 5, Jaundice and Physical Anomalies. This whole section is about applying our framework to spot exactly what is abnormal.
Okay, I really need you to listen closely right now, because this next concept is a massive, massive exam trap. You absolutely have to know the difference in timing here. Physiologic jaundice, that's normal. It appears after the first 24 hours. Why? Because newborns just have extra red blood cells breaking down, and their liver is still a bit immature, so it's slow at processing the bilirubin. Totally normal. But pathologic jaundice, that appears within the first 24 hours. So if you've got a baby turning yellow at, say, 12 hours old, that is highly, highly abnormal until proven otherwise. It's a huge red flag indicating an immediate threat, like severe blood incompatibility or excessive red blood cell destruction. So whatever you do not ignore jaundice in the first day of life. Let's map out some physical anomalies directly to their immediate threats. Think about a cleft lip or palate. The baby simply can't create a tight seal, which leads to poor suction and a huge aspiration risk. Your action? Feed them upright using a specialized nipple. Now, what about spina bifida, or an open neural tube defect? You have exposed neural tissue that is incredibly vulnerable to trauma or a nasty infection. Your action here? You keep that baby prone, on their stomach, and you protect that sac at all costs. And then there's a TE fistula. This is an abnormal connection between the trachea and the esophagus. These babies are going to choke, cough, and drool. The immediate, terrifying threat is severe aspiration. Your priority action? You stop oral feeding immediately, literally right then and there. See how that works? You just map the physical defect straight to the nurse's very first action. And just like that, we've made it to Section 6, the exam cheat code. We've gone through all the deep reasoning, so now let's pull it all together into some rapid-fire connections.
I want you to basically lock these high-yield connections permanently into your memory, okay? You see APGAR in a question, you instantly think transition to air. Vitamin K, bleeding prevention. You get a scenario with a cold baby, your brain should immediately scream hypoglycemia and hypoxia. A preterm baby struggling to breathe, bam, lack of surfactant. And seriously, notice how frequently both LGA babies from diabetic moms and SGA babies who had poor growth trace right back to the exact same threat, hypoglycemia risk. It's all connected.
Let's finish rounding out this cheat code. Remember, jaundice before 24 hours? Always, always abnormal. If a question asks about phototherapy, think about the why. The light actually alters the structure of the bilirubin so the baby can easily excrete it in their stool and urine. For babies dealing with NAS or neonatal abstinence syndrome, they are withdrawing from substances. Their little nervous systems are wildly overstimulated. So your nursing action? Decrease stimulation. Dim the lights, keep it quiet, swaddle them up. Safe sleep? It's always, without exception, back to sleep on a firm, flat surface. And if you see TE fistula, it's a strict, absolute no oral feeding.
So, as you walk into Exam 4, I really want to leave you with this one final thought. The next time you're staring at a question about a grunting baby, a freezing cold baby, or a jittery baby, Are you just going to randomly guess an intervention from some list you memorized at 2 a.m.? Or are you going to pause and ask yourself, why is this happening? What is the immediate threat? And what is my very first priority action to save this newborn? Trust the master strategy, guys. Lean into the why, and I promise you are going to absolutely crush this exam. But honestly, more importantly, knowing that why is exactly what's going to help you save a tiny little life on the floor one day. Thanks so much for joining me on this explainer, and hey, happy studying. You've got this.